Ever have a epidural? No? Yeah, would you deliver?
Yeah.
Okay. They go in your back and you hear that pop. That's them actually going through the dural sheath. Okay? Not cool. Or cool, depending on what.
Real cool afterwards.
That's what I'm saying. Okay?
Not so cool when they miss 3 times.
Ooh.
That's why they should take an anatomy. Okay?
So would it be the same with the spinal tap?
So that is a spinal tap.
That is.
That is. Okay. Long story short, when I was paramedic student like you, I was in Vassar, and I was in the old Vassar. And the old Vassar made you wear medical scrubs, and they made me wear a white coat. And so I'm in the ER next to some, and they're like, hey man, we got an epidural, we might need a spinal tap. And I'm like, oh, they got meningitis? And I'm like, yeah, that's awesome, right? I go, they have a positive Brzezinski, positive Kiernan. And the resident's like, cool man, you ever done an epidural? And I go, no. He goes, do you know where to do it? I go, yeah, spinal cord level, L5, S1, right through the center, you'll hear a pop. He goes, cool, go do it. I'm like, okay. So I'm like doing a surgical, getting everything all set and done, and I do it, right? And they're like, man, you're really good. Like, what school are you coming from? I'm like, Dutchess Community College. And everyone looks and they go, what? I go, yo, DCC is up in their curriculum. And Arshad was there.
Yeah.
Arshad looked at me, and yeah, he was one ambassador.
Yeah.
He looked at me, he goes, we're just not going to tell anybody about this. And just yeah. But at least I knew where you find meningitis. It's that spinal tap at the bottom. Now,
Please do not do spinal taps.
No.
It is outside of your scope of practice.
I'm not saying you do it.
You went to doctory school.
They are.
I'm like, they're all gonna be doing things they're not supposed to.
Don't do what I did. Okay. So when we think of epidurals, though, we think of fracture because it's literally pulling that hard leather case off of the brain. What color is this?
Red.
Red. Great. You're colorblind. So we know that this is arterial blood. So is it slow or is it fast going?
Fast.
Fast going. And so this is what we have in our trauma. This is usually younger people itself that have trauma. We get fast growing bleed. This increases ICP or intracranial pressure. We gotta go. And this is when you see, everybody see this, decorticate, and then, we don't like that. Anyway, everybody here, you see this, and you see that, we in bad shape, okay? All right. This is usually accompanied with trauma, car accidents, and they don't have a helmet. This is what I suspect. One eye will be blown, maybe the other eye will not be, okay? But it gets real nasty because the whole thing is pressing down, and there's an opening at the bottom of your skull called your foramen magnum, and that's where your respiratory, your medulla oblongata sits. So they start having respiratory problems. Okay. This is what people my age and older get. Now, when you get slightly older, your brain what? It shrinks. There's a lot of things that happen with age, okay? It isn't cool, all right? But your brain shrinks a little bit. And so we're looking at your middle meningeal artery right here, right? Because it runs along from your internal carotid. But this one, we're looking at bridging veins, veins that go over the sulci. Sulci means shallow, gyrus means the bump, okay? And so you get a bridging vein, a little bit of a rupture, and it's a slow bleed. So you get a senior citizen who hit their head and then goes to sleep and then doesn't wake up. Okay? So, what would make this worse? Coumadin, heparin, right? Because now, I mean, you just touch them and they bleed, right? So you want to make sure, right, that if they have a history, here's my general rule of thumb. If they're on a blood thinner and over 70, and they hit their head, CP. We just don't. They're on Medicare, Medicaid, and I don't ever want to have that look in the mirror like, oh shit, I should have caught that. Okay? And so I had a gentleman, 92 years old, slight bump, and he literally bumped his head while he was coming up the stairs with laundry. He nicked himself. Scalp wounds bleed a lot. I looked at him and I go, man, you bumped it pretty hard. There's a big bruise right there. I go, if it's big enough to bruise on the outside, it's big enough to what?
Who's on the inside?
Went in, massive bleed. They drained it, he was good to go. And he wanted to go to sleep. You know what I mean? So like, a quick check, we were right by Mid-Hudson. I'm like, hey, have him check you out. And he didn't want to go. Imagine being 90, you know, like 80, 90 years old, not wanting to go, right? So he said, I'm fit, I'm fine. So you know how I tricked him? I kidnapped him. No. I said, I know you're fine. You're a stud. Let's get the test to show your wife how awesome you are. He's like, yeah, I'm gonna take this test and show her. So sometimes you're gonna have to learn how to talk to people. I don't wanna get him angry. I said, no, you're fine, man. Let's just do this. Let's make sure your wife's worried. She's gonna nag you all night. Okay? You really wanna have a headache all night too? I get this checked out. You got a clean bill of health, and you're gonna have a good night's sleep before you come home with nobody nagging you. He's like, oh, nobody nagged. Okay. And he got scanned, and I saw him, I think 3 days later, he gave a call, and I had coffee with him. Okay? It was good. So we want to know that the subdermal, this is anytime you got an older person, right, and they're on blood thinners, or they're just older. Okay? This is bad. This right here is bad. And that's where you blow an artery on the inside. Okay? And it doesn't have to be traumatic in nature. Okay? So I want to kind of review something in the areas of the brain. Frontal cortex, personality, parietal sensation, temporal, language, mathematics. You have to understand temporal. When they get a blow to the side, that middle meningeal artery is also your middle cerebral artery. That's why most people have problems. Their face goes down because they're homunculus, but they can't articulate something, right? Because that part of the brain is what causes your articulation or your comprehension center. And it's all supplied by one artery, okay? And that artery is your middle cerebral. If it's a frontal cerebral stroke, they're gonna have changes in personality right there. And so, imagine getting hit there repeatedly over your lifetime of 20 years, playing football. That's where we see a lot of CTE is up. And that's where you see some people who have CTE or concussion-like syndrome, they'll have a personality change. They'll be able to articulate. I had a young gentleman in Marlboro who was a boxer. He was not a good boxer. And so he was having seizures, but he had CTE because the frontal part, his personality changed. And his mom was like, he used to be so sweet, now he's aggressive. And I'm like, oh, he needs to get, man, they found massive amounts of CTE in the young guy. Okay? So that's something you want to think about. Brainstem, they got breathing problems, look for problems in soreness back there. You want to make sure that you splint up. Okay. So we got Broca's, which is motor. Vision is occipital cortex. So that's why when you get hit in the back of the head, you end up sometimes losing your vision. You ever fall and smack your head in the back of the, like you go ice skating and everything's, you know, or your spouse comes off and just whatever. Not saying that happens, but it happens. It helps. So that happens, and that's where you want to make sure that you're checking. Okay, you do your physical exam, and if you feel a depression or bulging outwards, right? One, don't keep palpating, okay, because we don't want to press the skull into it, right? We want to make sure that we find the deformity, go over it, don't press in, find the edges, and maybe put a pillow behind that or an O-ring behind that fracture so they're not laying on it, okay? All right, so we want to talk about aphasia. And aphasia is the difficulty with speech. So, like you to, sir, what's your first name?
Jed.
Jed. Ask me how I'm doing.
How you doing today?
Cat, bird, chicken soup. Well, I heard what you said, but I couldn't express anything. Okay? Cat, bird, chicken soup, rat, macaw. And so that's expressive aphasia. But I know what you said, and I know what I should say. So how am I going to interact? What am I going to be on the inside? I go, damn it, I know the answer. You ever been in an argument and you know the answer and you couldn't get it out? Right? For sure. What do you get? You get frustrated. That's the number one sign of it. Because you can't express yourself. You hear it, you understand it, you know what you should say, but you can't do it. So what you'll say is, don't worry, relax. I understand you're having a hard time getting it out. Can you write it out for me? Because that's a different part of the brain. See if they can do that. That would decrease their frustration. Okay? Versus receptive aphasia. Ask me how I'm doing. It's a nice day out. I'm not even understanding what you're saying. So you're going to get an answer that doesn't relate to what you're saying, but the sentence makes sense. It's grammatically correct. Because they can express a full sentence, but it's not going to, because they can't understand what you're saying to me. Now, are they going to get frustrated? No, because they think they're saying the right answer. Does that make sense?
Input, output again.
Yeah, chicken soup. Right. But that's why, so you have to know if they're getting frustrated. Don't worry, I got you. We're okay. Can you write down your name for me? Okay? Now here's a wild one. Most language centers are on the left side of the brain. Okay? That's why when you get a left-sided stroke, you'll see the right side curl up because it crosses, but they'll have problems with their speech. Yes?
I had a TIA when I was 17 and I had aphasia.
Yeah. You get it on the left side, right?
Yeah.
You're left side dominant.
Mhm.
Okay, you speak a second language?
No.
Okay. Anybody here speak a second language? Okay. Where's that side of the language at?
Right.
Your other side. So I had a patient who had a stroke, and she couldn't talk to me in English, but she could talk to me in Spanish. I asked one of the observers, what language did she learn first? And she goes, she's from Puerto Rico. I go, oh. So she couldn't talk to me in Spanish, right? Sorry, she couldn't talk to me in English, but she could talk to me in Spanish. This is what she learned first. She learned English second. So when we did MRI, I bet one of the guys, I know what side is on. Dr. Moore. Yeah, he owed me a cup of coffee. Okay? So your first native language is not going to be, it's going to be in your primary brain center. Your secondary is going to be here. Now you're also going to notice this a little bit in your career in EMS. People that are totally fluent in English, when they get older, they start reverting back to their first language. I don't know why it happens. It is the worst. My mom is literally like an old Confucius lady right now. She just speaks like with her hands back here, and she speaks Chinese to me. And I never spoke Chinese as a kid with her. And I'm like, why are you speaking full Chinese? You've been here longer than I've been here. And yet, but this is, so don't get frustrated. This isn't because of a traumatic, this is just natural kind of aging process. So you want to make sure that you get timing and you find out what's going on. All right, so we got damage, brochus, expressive. Okay, so this is your vascular supply. Everybody knows this off the top, but let's just say you didn't, okay? They don't show the first arteries off of the heart. What are the first arteries off the heart? I gave it away. Coronary. Your heart's green. If your heart doesn't get the first blood, you die. No need for a brain if your heart doesn't pump, right? So then you have your aorta, and I want you to understand, brachii means arm, cephalic means head. So on your right, brachiocephalic, brachial meaning subclavian, cephalic meaning your carotid. The left side has a carotid only, then your subclavian afterwards. That's how important your brain is, that you're going to get a supply from your internal carotids. Okay? But you get another supply just as a backup. Okay? If things are important, we're going to get two blood supplies. Okay? So the next one is your vertebral arteries. So we want to make sure that now you have 4 blood supplies. These aren't nearly as big as these. And I can all give you a reason why these give more pressure. Who here slept at night and felt their heartbeat? Hear it in your skull. Anyone ever have that when you're sleeping? You're like, I can't sleep, I can hear it. That's literally the amount of pressure going through your vertebral arteries, actually not your vertebral, your internal carotid, before it goes to the circle of Willis. That's how much pressure is coming up your internal carotids. Your internal carotids in your aorta, they're not elastic, right? Your radial arteries feel bound, your radial, your brachial. These are not elastic because they withstand pressure, okay? Your vertebrals you don't feel. So the brain is greedy. 20% of all blood. 20% per minute. So that means anything that affects your blood, right? Such as low glucose, low oxygen, low volume, okay, is going to give significant problems to your brain. Okay. J-term crowds, vertebral basilar. They join at the circle of Willis. Okay? And when they join at the circle of Willis, this allows, if you have a small clot here, that your blood can go all the way around. Okay? I mean, it's just another system, so in case one gets blocked, you have another one. Who here asked their parents for money ever? Come on, man, we all ask. Okay? When you couldn't ask your mom, who'd you ask? Dad? And who do you really go to when you're down and out and your mom and dad won't give you money?
The street?
Your grandparents, man, you hit them off. You hit them off. And that's what you want to think of the circle of the world, okay? That if you can't get anything out of mom and dad, you hit up your grandparents, okay? You tell them how you're your favorite. You'll never put them in the nursing home. You do what you need to do, okay? But that's the circle of Willis. You're getting blood all the way around, and so if that's what gives you collateral flow, it's a backup system. And that's what you need to know, that your body, but what happens, right? Well, we have drainage, because every time you have a heartbeat in, does your head explode? No, so you gotta have drainage out, okay? That's through your internal jugulars and your venous sinuses. So now that we know that we're getting blood in and we're getting blood out, right? You have to understand that your dura, that's your brain, getting all that blood, now is that bubble wrap, your cerebral spinal fluid, and then your dura over it. So your brain is going to be insulated. Okay, here we go. Spinal cord passes through the very nice. Conus medullaris, that's the tapering point of the spinal cord. Okay. Just so you know. He's only like 1 or 2 inches taller than me. Okay. But his spinal cord is the exact relation in length that mine is. And so when we hit puberty and we have that growth spurt, some have more than others. Okay. I'm tall in okay. What happens is that spinal cord stays at L1, and that allows us to take a spinal tap right around L5S1. In children, though, since they haven't had that, that spinal tap has to be more careful. We've got to go a little bit lateral so we don't hit the spinal cord. Does that make sense? And so that's something to know, because when you get a fracture below L2, I know I'm getting mostly spinal nerves. If I get a fracture above L2, we're now talking cord and we're talking central nervous system. That make sense? Okay. So, cord hanging loose, actually anchored to the blank via the coccygeal bone. Technically, the cauda equina is considered what? It's the fanning of spinal nerves at the bottom. That means horse's tail. The conus medullaris is actually the ending of the spinal cord. So why don't we say the terminal strand, or the end strand? We're going to call that the filum terminalis. And that's the final tether all the way down. That's what keeps your spinal cord straight, and that's what keeps it anchored all the way down. Okay?
I think they got shipped.
I didn't make that. Okay? How many plexus group branch off the spinal cord? Well, you got your brachial plexus, you have your lumbar plexus. You technically have a sacral plexus, and you have a cervical plexus. So in reality, it's going to be 4. Cervical plexus, brachial plexus, right? Lumbar plexus, sacral plexus. Okay. Review this one, because I teach it differently, so I'm just making sure. Transmits roots from the spinal cord to the extremity of the body. Okay. This is where we get a little bit difficult when we break down spinal nerves. Okay? So, I'm going to borrow you. No. Borrow you. Fighter. Don't fight her. Okay? Alright.
My money's
You're
on
going to be
Kenzie.
here. You're going to face front. Okay, you're going to come here. Okay, great. I need you to be here. No, keep going. Keep going. There we go. I need you guys. You're going to hold this hand right here. Okay. All right. This is a spinal nerve. She's the ventral root. She's all motor and muscle. Mr. Barber is all sensory. He's a sensitive soul. But he's big. He's the dorsal root ganglion. This is all the cell bodies. Okay? When you guys are together, you're mixed. You're both motor and sensory. Okay? This allows each nerve to come out of the spinal cord correctly. All right, you guys, you're a great dorsal root ganglion. Okay? So you want to understand that your dorsal part, your dorsal root ganglion, is all sensory. So if I get a stab wound, and why are you feeling? Here, dorsal angle, and he can't feel down, but he can still move. What part did he get hit at? He got hit at the dorsal root, or the dorsal root ganglion. If he got stabbed in the front, but he had sensory, but he doesn't have motor, I know that's the ventral part. Okay? Now he got sliced here. He's now losing sensory and motor because it's both of them mixed together. Does this make sense? Okay. So that's how you want to do spinal nerves. Spinal cord consists of ascending tracts, meaning going up, and descending tracts. Which are the correct references for those tracts? Did you guys study this at all? Yeah, be honest. Yay or nay?
They should have covered it in AMP.
Okay. With Dr. Butal, right? No, Donabala.
Donabala.
They talk about epididymal cells. Epididymal, oh yeah. They made me take A&P, believe it or not, even my doctorate, so I used to mess with them all the time. I was like, hey, Dr. Donabala, retinoblastoma, it's between this and this layer, right? And he'd be like, yes. How do you know that? I go, oh no, I saw it on YouTube. Like, I would just mess with him every class. It was great. It was awesome. All right, what you need to know is ascending tracts and descending tracts. Ascending, meaning coming from the ground up. So we want sensory. So we're going to call it spinal to your cortex where you interpret it. That's the direction. So spinal cortical tract. Okay? How about if we go to the spine to the thalamus? That senses pain and temperature. These are ascending tracts. This make sense? Descending tracts are your what? Motor, because I'm making my brain command it. We doing okay? So you just go by the Latin part. When they mean cortex, they mean from your cortical brain in the front, that precentral gyrus. Okay? So. No, I'm not.
When the box fell off, did the battery pop?
Might have. Please live.
You just turned it on.
Alright. Alright. Alright.
Turn it off, turn it back on. That's
All
always
right.
right.
Okay, spinal cord, we look. This is your conus medullaris. It's a cone at the end. So it goes all the way down to L1 or L2 in most adults. The tail-like is going to be all spinal nerve. It's going to be coming out. That's called your cauda equina. All right? So it conducts the PNS, meaning going out. There we go. Ventral, right? Motor, efferent or output. Afferent meaning sensory. Affected versus effect. Right? Think. I always say this. I always use input output. So double check on that one, okay? All right. Get on this one. Ooh, this is a monosynaptic reflex.
You're gonna probably have to move it over to the other screen so they can see it.
Just okay. Come on. Okay. So, I'm going to do this in simplest terms. Okay. All of you have reflexes for heat. All of you stepped on something and pulled back, like a Lego or something like that. What happens is, before your brain can even interpret it, because it's such a painful stimulus, you sense it, it goes in your spinal cord, and it shoots right back to the muscle that pulls away. Okay? Then your body's like, oh, that was hot. Have you ever touched a stove and you're like this? That's before your brain can even sense it. It senses damage before. This is called monosynaptic pathway. It's one synapse in the spinal cord. Okay? So this is a reflex. Okay? So since it doesn't go up or down, this is contained within. Okay? So when you give somebody a reflex hammer, I don't know, do you guys carry reflex hammers? No? Okay.
Bernadette says I'm not allowed to have a hammer.
I don't think you should.
She shouldn't have any kind
You
of.
should go, you should have like crayons.
Not you can.
That's it. You don't need it. So a monosynaptic is a pain reflex. When people don't have pain reflex, right, it's this nerve to the spinal cord that got cut. Okay? If the spinal cord got cut, they can't modulate this. So you'll see people stroke. They can't go back down. They can't relax. So that's what you want to be. When a person can't feel something, that whole peripheral nerve got cut. They don't have that arc. If their damage is up in the brain, they can't stop the arc. Okay? Questions? Makes sense so far?
So it's an automatic response to
A
a
painful
stimuli.
stimulus, it can be pain, it can be just a stretch reflex, meaning your Achilles got stretched, your patella got stretched at the doctors, right? That's a monosynaptic, but pain is the one that you guys are normally accustomed to, right?
It's mediated
Hot
in
stove.
the spine.
Yeah, it's never mediated by the brain.
Mhm.
It's interpreted by the brain.
Mhm.
It was on
after.
the test, right? It was on the quiz.
Yeah,
So
it's mediated by the spinal cord.
What about what about if you like flinch if somebody like swings at you but they
So-
hit you?
Flinching, that's a corneal cervical reflex. You actually didn't process that they're going to hit you. You processed that there was motion. And that's your ocular motor and your ocular synapsing with your cervical spine and your cerebellum. You do that, right?
So it's similar.
It's
going straight to the
similar.
spine.
Yeah. Okay. We have cervical reflexes, right? Anybody been to the eye doctor and they well, and you can't help but blink? That's a corneal blink reflex. Okay? I got another reflex for you. It's a cool reflex. Okay, this is how I know that they're in game. Her nose, and her eye. That's it. Okay? Anyone ever pluck a nose hair when you start sneezing? Another one. Okay, we have a few reflexes. Gag reflex is another one. When you hit the UV, I think you're choking. Okay? So we have reflexes everywhere to protect us. Okay? And we want to protect the things of us that are the most valuable. So your eyes are super valuable. Your ears, anything you ever get your ear wet in the shower and you're like, that's a monosynaptic reflex. Okay? And you can't mediate that. That's all done in the spinal cord. The cranial nerves is done somewhere else. There you go. Let's do one more video.
I have no clue what I just watched. I'm actually off the streets. I was watching. I should have watched that before.
I like it because it breaks it up for a few
Oh,
seconds
oh, I'm
for
not
them.
saying it
Can we
doesn't.
learn
I'm
everything
not saying it
different?
doesn't. You gotta warn somebody. You gotta warn somebody when things are supposed to
You wanna
be-
give them a couple-minute break?
Yes, I do. They've been lecturing for a while.
Take a nice easy break.